It's my pleasure to introduce our first presenter, Gerhard Diller, I think from Münster, Germany. One of the treats about coming to meetings like this is getting to hear from people whose work, whose research you really admire. And Gerhard is one of those people, so I'm looking forward to your presentation.
Thank you for this kind words, and I would like to thank the organizers for inviting me. It's an interesting topic also for me, and I enjoyed preparing this talk, I must say. So I hope you find it interesting as well. So it's about prescribing PDE5 inhibitors, which, you know, we could summarize as Viagra for erectile dysfunction for patients, for Gooch patients, and whether it's safe and what the problems are. So let's look at the definition, and this definition is quite interesting. So what is the definition of erectile dysfunction? If you look at what the NHS, the National Health System in England, says, of course, erectile dysfunction is known as impotence. It is the ability to get and maintain an erection. But what they went on to say shocked me a little bit, to be honest, because they then went on to say it's a very common condition, particularly in older men. That's fine. But then they say they define older men as men with an age older than 40, and that is a bit shocking, I must say. So now, if we look at the prevalence of erectile dysfunction in males, then there is indeed, if you concentrate on the right side, an increase in the prevalence of erectile dysfunction as patients get older. So if you start from 40 to 70 years, so as patients get older, this becomes more and more of a problem. And unfortunately, it's also associated with heart disease. So people with heart disease tend to have more erectile dysfunction compared to other groups of patients. But it's not only heart disease and age that lead to this condition. It's also things like diabetes, hypertension, and of course many psychological conditions that affect erectile function and may lead to erectile dysfunction in this patient. So I think this is important to keep in mind. As our patients grow older, I think this will increasingly maybe become a problem. So I'm not going in detail through all these points, but the point that I wanted to make is that, of course, we've got these drugs, the PDE5 inhibitors, to treat erectile dysfunction, but just because we've got a hammer, not everything is a nail. So I think it's quite important to keep in mind that this is a multi-causal disorder. And so, of course, you have to refer the patients for a urology opinion because there are structural abnormalities that may lead to erectile dysfunction. It is also related to endocrine disease, so diabetes and other forms of endocrinological disease can lead to this condition. So these patients benefit from a thorough workup before we hit them with the drugs. And of course, besides the purely organic issues that are at play here, there are a huge number of psychogenic reasons for erectile dysfunction, and this also should be worked up. So, what is the usual treatment of erectile dysfunction? If you look at this review taken from a urology journal, of course, we've got the PDE5 inhibitors, which are the mainstay of therapy, I would think, in the current era. But again, it's important to identify potentially curable causes of erectile dysfunction in these patients, and lifestyle changes may help, and education and counseling may help in some patients. And then, of course, again, it's, I guess, important to involve the experts in the treatment path of these patients, because the potential for treatment doesn't end here. There are a number of more, let's say, invasive and more advanced ways that this condition can be treated with implants, etc., and injections. So just to keep in mind that it doesn't end here is one part of the treatment of erectile dysfunction, but there are many other things that should be considered. How do PDE5 inhibitors work in this condition? Well, basically, they decrease intracellular calcium in the smooth muscle cells in the corpus cavernosum, and so there is more blood entering the structure. So they act on the cyclic GMP pathway, and by decreasing calcium, they lead to a smooth muscle relaxation in this condition. Now, if you think about PDE5 inhibitors in our patients especially, then I think it's important to consider what are the potential side effects and contraindications of the drug. So these drugs in general are relatively safe, but they have a number of contraindications which are important to be kept in mind. I guess the most important one is an absolute contraindication to give a PDE5 inhibitor together with a nitrate. I mean, not many of our patients, of course, need nitrates for ischemic heart disease, but you shouldn't combine them. And the same is, of course, true if a patient is already on a PDE5 inhibitor, for example, for pulmonary hypertension, and riociguat for pulmonary hypertension, which is a soluble guanylate cyclase activator, but also acts on the nitric oxide pathway the same way that PDE5 inhibitors do, is also a contraindication. So these patients should not be given PDE5 inhibitors for erectile dysfunction. And then there's a relative contraindications for alpha blockers for hypertension. Antihypertensive medication in general, if it's well controlled and established, is not a contraindication for this treatment. So the worry here, of course, is that if you combine these drugs with other potentially vasodilators, this leads to dangerous hypotension and endangers the patient. The other thing to keep in mind, there are a few ophthalmological contraindications, so it may be worth to refer patients who have a history of ophthalmologic disease to an ophthalmologist before starting these drugs. There's a condition especially called the ischemic optic neuropathy, which has been associated with the drug, and so patients who have these conditions should not receive these PDE5 inhibitors. Renal and hepatic disease are relative contraindications because of the metabolization of the drug. And there are some interaction with other drugs that act on the cytochrome P450 pathway. And again, this is something to keep in mind. Now, what are the main side effects of these drugs? Of course, not very surprising. They're vasodilators, so they lead to flushing, they lead to headaches. They may lead to dyspepsia by relaxing the esophageal sphincter. Nasal congestion, again, because of blood inflow into the nasal mucosa. And there are a few patients that report visual effects, something that has been referred to as blue vision. This seems to be a transient issue lasting for approximately 3 hours. So these are the relative numbers in this publication. So 16% of patients reported headaches, approximately 14% flushing, and all the other things are much more uncommon. This is a graph showing the impact of PDE5 inhibitors, sildenafil or Viagra in this case, on blood pressure. And you can actually appreciate that it's not that dramatic in healthy individuals. There is some drop in blood pressure, but it's only a few millimeters mercury. Still, of course, we may be worried about a few patients who have left-sided obstructed lesions like aortic stenosis, or the potential to have an increased right to left shunt with systemic vasodilation. What is illustrated here is the effect of nitrates. So this is the combination of nitrates and sildenafil, and you can see that the blood pressure drop is much more profound, and this is the reason why it's contraindicated to combine these things. All right, so what is the association between PDE5 inhibitors used for erectile dysfunction and cardiovascular mortality? Because this is, of course, the question that we have to ask if you think about safety in this setting. Now, this is an overview of data derived from placebo-controlled trials for Viagra, and you can see the numbers of patients included are quite high. And what is done here, it's been distinguished between patients with ischemic heart disease and those without ischemic heart disease. And the main worry was whether myocardial infarction is a significant side effect of this drug. And if you compare the placebo with the Verum, the sildenafil group here in patients with ischemic heart disease, you can see that both groups had a 3% occurrence of this myocardial infarction. So it doesn't seem that myocardial infarction per se is associated with the use of this drug in patients with ischemic heart disease. So the cardiovascular mortality is difficult to be attributed directly to the drug. The issue is, and this makes our task much more complicated, is that one is to look at the risk directly related to giving PDE5 inhibitors. So if anybody would just take it for the sake of taking the pill. And of course, I've shown you data that this is relatively safe. But the problem is, of course, that people take the pill for a reason. They take a pill for having sex. So, and so this gets us into the problem that, of course, then we are sort of overlapping there. So they get both the risk related directly to the drug and the risk related to sexual activity. And to make things maybe even worse, there is this issue, of course, that PDE5 inhibitors may enable sexual activity in men who would otherwise not be able to be physically and sexually active in that way. And it also reduces this post-ejaculatory refractory time. I thought this is something that only electrophysiologists use, the word refractory time, but apparently they borrowed it from the urology community. And this, of course, again, increases the physiological cost of sexual activity. So this is then the problem where we're heading to, of course. And this is just to illustrate this point. This is a famous publication from one of the high-impact journals in the field. So the Sun reported on this recreational use of Viagra, and it just illustrates this issue of this increasing the physiologic costs. This unfortunate gentleman who bet to take a bottle of Viagra and engaged in a very prolonged period of sexual activity, and unfortunately he died. And of course the issue here is that this is of course only enabled by taking the drug in an extreme overdose. He took a full bottle, that's 30 pills of Viagra. So. But I think it illustrates the point. So it enables people to do things that they would not be otherwise able to do. So what are the physiologic effects of sexual activity? This is irrespective of taking PDE5 inhibitors. These are studies that just looked at sexual activity itself. And if we look at heart rate and blood pressure in this various papers, you can actually see there's a moderate increase in heart rate with sexual activity. In general, and blood pressure rises a little bit. It's not terribly high, 60 to 70% maybe at most of predicted heart rate. And this is an older study that I found from dating back to the 1950s, where somebody actually traced the heart rate of males and females during sexual activity. So it shows the same thing, 140 beats per minute was the maximum achieved here. Now, unfortunately, I have to contradict John Dienfield a little bit, because yesterday in his presentation he said that sexual activity is equivalent to 5 to 6 mats, and apparently, looking at the literature, this is more what he was referring to is more like an Olympic type of exercise. It appears that it's more like 3 to 4 mats in general, at least according to literature that I could find. Now, 3 to 4 mats, metabolic equivalent, so this is 3 to 4 times the resting oxygen uptake, if you want to put it in perspective, is comparable to climbing 2 flights of stairs or taking a brisk walk or doing some gardening. So it's not that terribly, that much. And the heart rate I've shown is increases to 120 to 130 beats per minute, and there's some increase in systolic blood pressure. But I think this is something to keep in mind, because of course if you want to prescribe these drugs to patients with congenital heart disease, then they have to at least be able to sort of achieve something like that to take advantage of the drug and not to be at risk, of course. Now, what is the general risk of dying during sexual activity? And of course, it's difficult to get data on that. And this is data that is derived from some large autoptic studies of people who died, of course, over the years. And of course, they go back quite a while to the 1950s. But you can actually see from these numbers that approximately 2 per mil to 1 or 2% only of these patients who died actually died during sexual activity. So it's not much. Now the bad news is it's almost all of them are males, at least for the man it's bad news. And it's the main risk factor is extramarital sexuality, unfortunately. And I'll show you some data on that. And there is agreement between the studies on this, unfortunately. So this is the numbers, again, huge numbers of autoptic studies, of course, but covering a long period of time. The risk is not extremely high in this general group of patients. Again, over 90% of the affected people were men. and 3/4 of them engaged in extramarital relationships, and then as a consequence, not surprisingly, the places of death are quite, interesting. So, so just summarizing this part a little bit, so that the majority of deaths took place outside a steady marital relationship. This is taken actually from this publication, and the authors were very explicit about what they found and what they thought. So located in prostitutes' apartments, etc. And but maybe from a medical point of view, more interesting is deaths also took place after sexual activity. So it ain't over till it's over. I don't know, till at least heart rate goes down, and so there may be events even after sexual activity, but related to it. So this is another study from one of the previously shown groups, but a more recent paper with even larger number, and again they reinforce the findings shown before. But what they actually split up here is the most frequent causes of death in this unfortunate patients, and you can see it's the leading issues here are myocardial infarction, pericardial tamponade, coronary artery disease, their medical history of myocardial infarction, and cerebral hemorrhage or strokes. There is one patient that I came across in the literature. There was a Marfan patient who died of a aortic rupture. So these are the things that have been reported. No congenital patients in this series. So we're a bit stuck because there's no data on Gooch patients. There's a lack of safety data for sure. Clearly, we have to advise for caution in patients with moderate or complex heart disease because of the physiologic costs, of course. We should be careful in patients with stenotic lesions or cyanotic patients because of this vasodilatory effect of the PDE5 inhibitors and the potential to aggravate either the stenotic lesion or to lead to a more profound cyanosis through to increased right to left shunt. And pulmonary hypertension is also something to keep in mind. First of all, because these patients may be on Revasio and sildenafil for pulmonary hypertension already, or on riociguat. And secondly, because many of them are quite sick patients. And then I think it's worth to thoroughly assess these patients with imaging and to exclude the arrhythmias and potentially addressable hemodynamic lesions before clearing them for PDE5 inhibitors. And exercise testing seems to be a good tool if you can use it, because it sort of gives you some reassurance that the patient is fine with this level of exercise. There is little guidance as far as I could find on our patients. This is a quote that I took from an ACC-AHA expert consensus document on the use of sildenafil in patients with cardiovascular disease, but of course they focus mainly on ischemic heart disease. And what they say, and it's quite funny to read, I'm not sure how to sort of sell this to our patients, but if the patients can achieve 5 to 6 METs on an exercise test without demonstrating ischemia or any problems, I would guess then ischemia during sex with a familiar partner in a familiar setting without the added stress of a heavy meal or alcohol is probably low. And they wish to stress that the physiological and emotional stress of sexual intercourse can be excessive in some patients, especially in those who have not performed this activity for some time and are not in a good condition. So I think it's a nice summary, but it's of course difficult to convey directly to the patient. And so I think if I were to summarize, I think the limited data that we have, of course we have to be cautious with this drug. But it is part of quality of life, and I think you have to think twice before you say no, and I think exercise testing, if you can do it, helps in most of the patients. Thank you very much.
That was great, by the way.
Thank you.
Is there any question from the Olympia room?
No, not at the moment. Is there any limit to what you can speak on, Gerhard?
Sorry?
Is there any limit to what you can speak on?
No, that was an exciting topic, I must admit. Yes, please.
Yeah, come here. Otherwise, they cannot hear you.
That's
no.
okay, okay, got it. Just wondering what your own experience talking to patients about this is and how often you get approached about this, and if you handle it with a sense of humor also.
It's a rare thing. I can't remember to have been approached recently by a patient asking for a prescription, but I'm sure they get them somewhere. I'm sure not all our patients, but a significant proportion of our patients are using these drugs occasionally, and. But I cannot remember to have been approached recently by a patient, which of course is an important point because this is even worse than having a controlled approach and having a think about the issues and having a thorough assessment if the patients just get it off the internet, the drugs. And
So,
yes, please, yeah.
so some of our patients, especially the sick patients, including Fontan and Eisenmenger patients, are put on Viagra for medical reason, obviously.
Yes.
Do you or any other has any experience with the positive effects of this medication on the sexual life of these patients?
This is maybe somebody from the auditorium has experience. This has been an ongoing discussion, and we had this discussion, I can remember, way back 10 years when we started putting Eisenmenger patients on advanced therapies, and there were some people that were saying you shouldn't put especially down patients with Eisenmenger syndrome on sildenafil because then they may get sexually more active and it leads to problems. But we haven't seen that, to be honest. I think that it's of course the same drug, but you give it 3 times daily. There's a constant plasma level that you get. There is no stimulus, sexual stimulus that comes together with the drug. So I don't think it's as helpful for this purpose. So I don't have personal experience with that, but I don't think it's a big difference. But the literature is very clear that you should not combine it. So if somebody is on 3 times daily Viagra, then it should not, or sildenafil, it should not give them Viagra in addition to that, because we don't know what's going to happen to the blood pressure. With there may be interactions that we cannot foresee.
Thank you very much, Gerhard. It was a very entertaining talk.